Hey guys, thanks for checking out Practical EMS. We try to give practical advice on this show and how not just to survive but actually thrive working in emergency medicine. I've had a lot of conversations with ER techs, nurses, doctors, APPs, but today we're going to shine a light on a little bit of a different role in the ER and people that often go unnoticed, but without them the ER would not function. These other roles are roles I have not really talked to before, but are a critical part of the ER team. The scribes, the patient access registration specialists, the EKG techs, the people that make sure we're actually looking at the right patient in the computer, making sure we're catching STEMIs with efficiency and speed, and they're just as much a part of the heartbeat of the ER as anyone else. Today I'm joined by Sean and Cheyenne. These are both EKG technicians, and Cheyenne also has experience with scribing. And I'm excited to get in and dig into their stories and get to know more about their perspectives. I've talked to like nurses and techs and physicians and APPs, but I was talking with Milton the other day and he's like, sometimes we just don't really feel like we're part of the ER team. And I was like, well, dang, I haven't talked to any of you guys on the podcast either, but I always have viewed EKG techs, which you're actually technically called. I looked it up.
We're exercise physiologists.
Exercise physiologists. Is that all of you guys then?
No,
is your
so
technical title?
There's a split between the EPs and the CV techs.
Okay.
So the cardiovascular technicians. So they focus a little bit more on the rhythm interpretation and the EKG side of things. Exercise physiologists do too, but they try to push us more towards stress testing.
Okay.
So that aspect is kind of like the main difference. Now with us, they're trying to push a little bit more of the CV technicians to go into stress testing, just so that they have a little bit more of a broader idea of kind of like what's going on in non-invasive.
Okay.
So it gives everybody an opportunity to kind of like do some stuff, but the EPs, like when we have the people, they want us to try to stress test, and then the CV techs is going to be more for the 12 leads, but either or both.
Is that like an additional certification then that you guys get, or they try to get you to get?
Yeah, that is an additional thing that they want us to have. With exercise physiologists, they want us to have the no, that's good. They typically want us to have the ACSM CEP, so that is the American Sports Medicine of College or something like that. That is going to be typically what our certification is going to be, and then the CVTs are going to be the CCT.
Yep.
So that is going to be the what was it? The cardiovascular technician.
Yep.
Yeah. So
certified cardiovascular tech.
So something like that. So those are the certifications for us that we need to have in order for us to stress test.
Okay.
The reason being is because it's a little bit more comfortable in the hands of being able to be knowledgeable to stress test, because when it comes to stress testing and EKG techs or conducting those 12 leads, totally different. Patient interactions a little bit more different. Whenever we do EKGs, it's a little bit more of getting the information. You don't really have to talk to the patient, getting that. But when you're conducting that stress test, you have to know everything about the patient.
Well, I imagine you're more like asking, like, are you having chest pain while you're doing this, or like asking about symptoms more? Is that right?
Yeah. Not only you're asking those symptoms, you're constantly monitoring the patient. So you're constantly grabbing blood pressures. You're constantly looking at those the rhythms while they're doing a stress test. You're checking their rates, their saturations, and stuff like that.
Okay.
Those are super key things, and there are protocols for those stress tests. I haven't started stress testing inpatient yet, but I am familiar with stress tests. I've done stress testing or modified stress testing in school. I have also done it when I was working in rehab. That's how I started generally.
Okay.
So we do modified stress testing before a patient comes into rehab to see where they're at
Okay.
And then it gives us an idea of what to do when we're making their exercise prescription.
Okay. But regardless, I mean, you guys are in the ER and you're part of the ER team. Like, we couldn't do our jobs without getting timely EKGs, getting them in front of a physician quickly. So I've always viewed you guys as part of the team, but I think you guys don't always feel that way. So that's why I kind of wanted to talk to you guys too and understand your role more. And Cheyenne, you were a scribe as well. Do you still scribe?
No, I don't
Okay,
anymore.
that's what I thought.
Yeah.
So you just do the EKG stuff
Yes,
now.
yep.
Okay. But we can also kind of talk scribe stuff too, because they're another very kind of small role that you don't really see, except if you work on kind of the front end, intake part of the ER. But they're also super crucial to our efficiency in the back. When a note's been started, or if we can discharge somebody from the front too.
Yeah, it definitely gives a provider a first perspective when a patient comes back and the HPI is already written.
Yeah. Yeah, and the notes already started, so they can kind of just fill in some holes, get a little bit more thorough history than we get an intake, and it allows the intake provider to move way faster than you could without a scribe.
Oh, yeah.
I've tried to do it without a scribe, and it's a rough gig
the amount
without a
of
scribe.
patients you guys do see in intake it's just overwhelming.
Yeah.
You definitely need a scribe.
Yeah, if you had to step back to the computer after each patient and put in their HPI and put in orders, that would be just too much.
Very.
So it definitely makes the department move a lot faster.
Mm-hmm.
Let's see what else here. Wonder if I should read this little preamble. No. How'd you guys end up in your roles? Can you tell me a little bit about what led you to the roles you guys are doing, or what led you to scribing before EKG stuff?
So I started scribing initially to just get patient encounter, even though it's not really hands-on, it is still patient encounter.
Mm-hmm.
And then I also wanted to really work closely with providers, just gain that experience, because I want to be PA, so I really just want to put my foot in the door and really know what it's like to work in the ER or just a hospital setting or just with patients in general. So I started scribing first, and I did that for about 2 years. And then since we work closely with EKGs, we're kind of in the same department.
Mm-hmm.
I started really talking with them and got interested in the EKG or the cardiovascular role. So I applied for that job and was able to get it.
Nice.
Yeah.
Is that what most scribes kind of do? Is it seems like most of them are geared towards this is experience for med school, PA school.
Yeah, it's a first step to patient interaction and getting along with providers.
Yeah.
So.
Yeah, and when I was in PA school, I was because we had some scribes in my program, and I was kind of does that count as bedside experience? But seeing what you guys do every day, I'm that's super valuable experience.
Yeah.
Because you get to observe the provider's interaction with patients a million times.
Oh, definitely. It's definitely broadened my my perspective and knowledge of how to properly take notes, and the ER perspective, how to do a physical exam, and my medical terminology has grown a lot more.
Oh, yeah.
It's definitely different than what they teach you in school.
Right.
That's for sure.
Well, and a lot of new providers really struggle with the note writing stuff, what needs to go in the note, what differentials do I need to think of? And so you have a huge leg up, I think, just writing so many notes.
The note taking is so different in ER versus primary care, because you're ruling out everything in the ER.
Yep.
So.
Yeah, I talk about that all the time. Our perspective is not really to diagnose anybody. It's to rule out all the bad stuff. It's, what tests do we need to order to make sure you're not dying?
Yep.
And then whatever's causing your chest pain, we don't necessarily care about. We know it's not a heart attack or a PE or, all the dangerous stuff. It is a very different mindset versus in primary care, you're probably trying to get to that in diagnosis and figure out what's actually causing it. Where in the ER, we just want to make sure you're not dying from whatever your symptom is. What about you, Sean?
So my first 2 years of healthcare, I was in outpatient cardiac rehab. And I think it's a very good idea, especially for individuals that want to get into the medical field. Is a great stepping stone position. The same thing with being an EKG tech. But when it comes to my experience with outpatient, it's a great idea for me to kind of figure out if this is the correct thing for me to do. So then I transferred into the hospital, where I'm doing where I potentially could be doing stress testing and EKGs. So that was my main role. And then when you're working in the hospital, I feel like that it gives us a whole bigger idea of what you can do. So in our department, it's a really good opportunity for us to go into maybe PA school or medical school. I know some people have been going that route. And then for me, I would like to go into echo someday. But that's why I really like cardiology, is because there's so much different types of stuff that you can do. You can go into devices. You can go into the cath
and that's
lab.
the nice thing about becoming EKG, cardiovascular tech, or stress tester, is that you could climb the career ladder and go into echo or the cath lab. It's just it's really nice.
Yeah,
you have options,
and it's a great. I think that's what entices a lot of people to do non-invasive, is because when you start off with EKG, it is a specific thing that you do, right? It's not broad. I know a lot of the EMTs or EMS, and what I see from that perspective is like, it is emergency medicine, but it's still like, you gotta know all these different things. And with our field, it's focused on that.
Right, very specific.
We are very specific. We focus on anything cardiac aspect, and it's a good way to kind of introduce the cardio aspect of things. And then as you move on, you'll move on to stress testing. There's some other things that you got to do, and if you want to go into echo or vascular, or if you want to go into cath lab, then it starts to broaden everything. And I think if you want to focus on cardiology, then I think that's a really, really good introduction.
Well, 12 leads are so complicated that, like, reading a 12 lead is like paramedic school. Like, we went over that for months and months on end, because it was such a critical thing as a paramedic to be able to, like, you have to recognize the STEMI. If you roll into the hospital and you should have called a cardiac alert, like, that's everyone's biggest fear, is you get there and then they call the cardiac alert and you're like, I should have done this from the field.
Yeah, so I that's probably one of the few things that I tell new hires is knowing those STEMIs, knowing when an EKG is abnormal, because at the end of the day, we can't diagnose anything, correct? But it is super duper important to identify those abnormal rhythms, so then you can let the provider know, like, hey,
as fast as you can,
as quick as you can, because there has been times, and this happens with a lot of people that have been in the field, is like they get a little bit complacent, right? And it has happened. Nobody's perfect, but they kind of just brush over and they give it to the provider. And not all the time the providers, they have other things that they're worrying about, right? They have like 12, 15 patients that they have to deal with.
And they may not have that patient in front of them, which is it's hard to look at a 12-lead EKG without having seen the patient. Because for me, when I work intake, like, I just talk to that patient and I'm like, I really want to see that EKG as soon as it's done, because I'm like, they look like they're having a STEMI.
And I think, because you've seen me, like, doesn't matter if they're a PA or an MP, like, I try to make sure that you guys are in the loop, because you guys are the provider at the moment. You guys are figuring out what to do with that patient.
Yeah. So, like, the way it works at one of our hospitals is it's always an APP in the front. So it's a nurse practitioner, a PA, and the way it stands now, we do not sign the EKGs, meaning we do not say this is a STEMI or this is not a STEMI. You have to go find a physician who's in the back. So it's a little bit more laborious for you. You've got to go find a provider in the back who doesn't have that patient in front of them, usually.
That has happened to me before, where there was I was at that location and I had a STEMI up in the intake, and I wasn't for sure what to really do at that moment. And the reason being is because when we were at the bigger location, the more busier hospital, everybody is there. Everybody is there to kind of notify and telephone to the next person. At that moment, I was like, shoot, well, okay, well, normal protocol, we'll go talk to Pivot, the EMT that's up front. And then when I went up there, I was like, oh, he's not there. So then I notified the EMT that was attending that patient at the time. I was like, you need to stay with them. I need to go.
Yeah, it's sometimes an odd position to be in, because you're like, this is a STEMI, but I have to find a provider to say this is a STEMI.
Exactly. So it was kind of funny, because I was running in the back because I was trying to hurry, and then I had like two nurses like yell, "No running, no running in the ED," and then I was just like, oh,
Right.
I have a STEMI out there, and the provider out there just, it was funny because like popped her head in the back, was like, "You got a STEMI?" So exciting. And then all everything was good from there on.
Right.
So,
well, there's
like,
not a lot of things in the ER that are super time sensitive. I mean, looking at it from the outside, most people would be like, I'm sure there's everything we're running around for, but we're really not. You're doing dozens of EKGs. Most of them are very normal, but it's that one patient in 50 that you're going to see that day that is very time sensitive, and so you've got to act quickly. And
time is tissue.
Yep.
That's the time. So like you gotta hurry up for those kind of things. Or something is to really identify is if it's going to evolve. So like you see these tiny little, and it's tougher for like newer people that don't really understand. But we look at EKGs all the time, right? And we can kind of tell that like, oh, there's a little bit something different about like what's going on.
Like not a STEMI, but the T waves are starting to invert in one contiguous area.
Yeah, you're starting to see a little bit of a ischemia. The J point is a little bit higher than normal, and it's super important for us as well to kind of identify, like, if the provider is busy, right? Then you're like, okay, this doesn't look horrible, but something could be off. We could go back and look into any prior EKGs and stuff like that and kind of compare the two.
Yeah. And even if they're not a STEMI, it matters for how we prioritize patients going to the back, because usually there's so much volume in most ERs that you have to say, well, this patient's next to go back, this one can wait a little bit, this one's not actively dying, or this one could be discharged ultimately from the front. They don't actually need to go back to an ER bed. And so even those subtle changes are like, okay, this patient needs to go back sooner rather than later.
Right.
So yeah, I mean, even those subtle things do matter. What do you guys have anything that's like you think are big misconceptions about your role that maybe providers have about your role, either as scribe or EKG tech, or even like nurses have that you think are kind of big misconceptions about your roles or things you would want them to know?
Yeah, I think it does take a lot to understand and interpret an EKG. And I feel like a lot of coworkers are like, oh, it's just an EKG. But you have to understand it and interpret it just in case there is a STEMI or something that's irregular to report to the doctor. And then as well as we have to get an EKG in a timely manner. We're like upholding a 10-minute stat. We have to grab an EKG within that 10 minutes. And sometimes we're just like, there's more EKGs and more EKGs. So it is a lot to handle, stressful at situations. But yeah, we work as a team and try to get them as fast as we can.
Yeah. We're only one person. So I think that's the biggest thing. And there are times where there's only one tech for the entire hospital.
Yeah.
Right? And I think the biggest thing is communication. Being able to not only tell the provider or the nurse, like, hey, I'm the only one here. Like I will get there as soon as I can. You want to try to de-escalate the situation because they're freaking out too, and they're like, sometimes they follow up with the question like, is there anybody else? And it's just like, no, I just told you, like, I will try to be there as fast as I can. And that's super important for us though as well, to kind of prioritize what needs to come up, right? What's going on. Sometimes when I'm on the phone with a nurse on the floor, typically you should be grabbing the ones on the floor, but I'm like, okay, what's going on with the patient? Are they having chest pain? Oh no, they're just a little tachycardic. Okay, well, then let me grab these ones in the emergency room real quick, and then I will head over to you. And that gives them a sense of comfort as well. Be like, okay, maybe he let me know that he's on his way. If there's any changes, typically I try to call back to try to notify. And the same thing with the ED, right? When ED calls me, but I'm on the floors right now doing a rapid, right? I try to make sure that, like, hey, I will try to be there as soon as I can. If I can't get it within the next 2 or 3 minutes, have one of the EMTs grab it, right? It may not be perfect, but, it's better to have something other than nothing, right, than waiting. So
yeah, I think the perspective is like resource utilization in the ER and understanding like which roles are the limiting factor, and you guys being by yourself a lot of times, you're the limiting factor. A lot of times as the provider, we see ourselves as the limiting factor. Like, this patient is, all the results are back. They're waiting on me to go in and see the patient and make a decision here. And so I feel like I can go in and interrupt whatever's happening, right? Like, if the nurse is talking to him, usually the nurses are pretty good at being like, okay, Aaron's finally here to come in the room. I'll pause, asking my question so he can see the patient. But with EKGs, I think it's almost a little bit different. Kind of like when imaging comes to grab a patient. It's really important to let imaging get them when they're ready to do the imaging. And so a lot of times I'll kind of do a rushed, quick HPI to allow them to go to CT or whatever. And EKG is kind of the same thing. Like, if I'm going to make the EKG tech stand at the door for 5 minutes while I'm talking with the patient, is that the best use of our resources when your job is very time sensitive and you have other EKGs to go do? Like, so I try to be like, come on in, do the EKG while we're talking to them, so that you're not standing at the door for 5 minutes wasting time when you've got other things to go do. And maybe not everyone realizes that. I don't know if you guys see that much, or if you're like, okay, I'm just standing here.
At times, yeah.
Sometimes.
Yeah.
I try not to stress over the little things because we all have our parts, right? We all have our jobs, and I think people need to be understanding sometimes, just because you got the stat order doesn't mean that you are the I think the only time we technically really have priority is a cardiac alert.
Sure.
That's when we can kind of push people away and be like, hey, let's get this now. But there are things that you guys have to do, or imaging has to do, whenever we're waiting for x-ray or something like that. Like, it's not the end of the world, right? Sometimes, if there has been times where I have imaging waiting in recess and I'm waiting in recess, and I try not to clash with them, but it's important to talk, what's going on with this patient. Oh, it's he's about to be on a BiPAP. Maybe getting the x-ray might be a little bit more important than maybe my thing, or it's like a car accident or something like that. Maybe I should grab this one. But there are times where if we're not too sure, just ask a provider or a nurse and be like, hey, do you want x-ray to come in first, or do you want me to quickly grab this EKG? If not, I'll come back in 5 minutes.
And that's why people need to view you guys as part of the team, because otherwise that communication doesn't really happen, and delays happen and stuff like that if they don't feel the freedom to communicate. If no one feels the freedom to communicate with everybody, then things kind of fall apart and things don't get done in the right order. And so I think it's important to view you guys as part of the team, to understand, do we need the EKG right now, or is the chest x-ray higher priority? And if someone's communicating that to you, you're not left to just wonder.
Yeah.
So I've never felt that way personally. Everybody has their part in the emergency room, right? And I don't be like, they don't really view me as one of them. I have my job to do, right? You have your job to do, and as long as it gets done, it's not about us. It's about about the patient. Is the patient going to be okay based off of our test?
Yeah.
Right.
Yeah. It's about the patient, but I also we're all a team, and we're all trying to get the patient the best care that the patient deserves in a timely manner. Yeah. We don't want them in the hospital all night. So
no, we don't. Yeah. And some people feel that way. I get it. I understand. They want to be part of that team, or they want that dynamic. But at the end of the day, it's not about us, right? We want to make sure that the patient is okay. And if our test doesn't get done right away, then we'll just have to talk to the provider. And if the provider has an issue with it, they'll get a final say so at the end.
Right. So
they want to make sure. And it's sometimes important to notify the provider, hey, do you still want this EKG? And they're like, oh shoot, yeah, let's get it knocked out.
Yeah.
So at the end of the day, for me, it's not that big of an issue. I don't see myself in that dynamic.
That's good to hear.
So
I think the vast majority of people do a good job of understanding everyone has a role. Even the physicians they're not everyone's boss. They have their role to play. Exactly. Yes, they have final decision on what's going to happen with a patient, but even the ER physician doesn't necessarily have the final say. They have specialists they have to consult with. Like as ER providers, we're like second best in every specialty, right? Like we have to be the second best cardiologist in the ER, but the cardiologist may have the final say on a particular patient. Like with STEMIs, we deal with this all the time. The cardiologist says, no, doesn't meet STEMI criteria. Work them up like you normally would, and we'll circle back, when their workup is back. Or surgery, we got to wait for a surgeon to come in and say, no, I'm not going to operate on this patient. This is not something surgical. And you defer to them because they're the specialist. So even the ER physician isn't the top of, this alleged hierarchy that we have in the ER. The physician's not the boss of everybody. They just have their role to play.
Yeah.
Just like all of us have our role to play.
Yeah.
It's very interprofessional.
Yeah.
Everyone plays a part.
Mm-hmm.
Yeah.
Anything about scribes that you feel like are misunderstood or?
Most definitely, especially in intake. When you see 90 plus patients with a provider and you're starting that note, it is overwhelming and it's a bunch of stress on you because you want to make sure you hit all the details you want for the providers in the back to read about that patient. So it is a lot when you're working out of 4 bays and having to write the HPI or finish a note on the discharge patient and all that at once. It is very hectic.
What do you prefer from the intake provider as far as like workflow? When they stand up, are they going to the bathroom or are they going into the next room? Do you like them to tell you?
Oh.
Do you just get a vibe for it eventually and you don't need them to tell you?
It definitely depends on the provider we work with. Some of them we're really close with and they will communicate with us like we're just going to get a snack or the bathroom. If not, they walk towards the bay and then start talking to the patient. And it's nice that we do have like the bays open and closed so we could hear if the provider is talking to a patient and we just run in there and quickly type our note. And if we do miss like some details, we'll just ask the provider.
Right.
But it is nice to have that communication with that provider.
Yeah. I try to, especially with Michael's one of the ones I've worked with the most at our less busy location, and I'll stand up and he immediately stands up. I'm like, going to the bathroom, Michael. I drink a gallon of water. I pee 5 times an hour.
It is definitely like, are we getting a note? Or
you don't have to go to the bathroom with me, Michael. I'm not seeing a patient.
I know he's ready to go.
Yeah.
I'll miss Michael as he goes to PA school.
I know. He was such a good dude.
He's okay.
Yeah, he's okay.
Hope he's not watching.
He deserves it though.
What does a normal shift look like for an EKG tech? Like, what's your workflow and day kind of look like? How many EKGs are you expecting to do?
Oh man,
it all depends whether if you're in the emergency room or if you're on the floors. So those are 2 different shifts.
And I imagine during the day, like business hours, you probably have coverage kind of for both.
Yep.
Night shift is probably like you've got the whole hospital kind of thing.
Kind of. So how it works in our bigger location, where there's a little bit more patient flow. We have 2 individuals generally in the emergency room during the day, and then we have 1 person that's on the floors. So they're taking care of all of the inpatients that are admitted into the hospital, all the units up there, outpatient, and there's only 1 person up there.
Okay.
And typically, it all depends on what's going on. If there are days where people are having chest pain nonstop, there are days where all the outpatient surgeries come in, and every single one of those outpatient surgeries, they all have history, so they have to grab an EKG, and they didn't grab one for pre-op. So like it's different for everybody. Typically, whenever I'm working in the emergency room, I feel a little bit less stressed out because I do have that other person there with me. I'm like, okay, if it does get busy, at least there's 2 people that can kind of divide and conquer everything. When you're up on the floors, you are by yourself the entire time.
Unless you're getting really slammed by EKG orders, then you could call downstairs to ask for help if they're not super busy.
Yeah, and vice versa.
Yeah.
So there are times where the ED is absolutely slammed, and it's your job as a good coworker to help them out. Like a lot of the times, like people tend to ask and be like, "Hey, we need help down here." Like we're all one team when it comes to that kind of stuff. So if it does start to get busy, like if it's on the floors and I'm in the ED and they're slammed, I'll call them and be like, "Hey, I'll go worry about this tower." right? Just focus on getting those ones. We'll worry about the ED in this tower until you can kind of get recollected and kind of figure out what's going on, and vice versa. Like sometimes the ED gets absolutely slammed, and I would come back down and help out.
How can you guys tell if the other tech is going to do an EKG? Does it like in the system or something? Does it say like, oh, this one's
I
in
would
process
assume
or
they
something?
go by like most critical or in order of time. And then we do see the orders on our screen about on the floors, and they do see ours on the ED.
So they can kind of tell when you're going to do that.
Yeah, and
one,
it disappears once you get the order.
Okay.
Yeah. So it's kind of weird, and it is kind of goes as time goes on, you'll kind of understand that workflow that kind of we have. We kind of have a dynamic of like, okay, we get one EKG. Typically, we'll get the other one, but you should still kind of check up to see if that EKG is grabbed. But you'll kind of see like if we have like 5 orders, it should get done within like 10, 12 minutes.